evening and welcome to the fourth Women's Health Initiative seminar. I'm Dr. Lisa Weisinger. I'm an internist with Trinity Health, and my office is in West Hartford, Connecticut. I am also the lead physician for the Women's Health Initiative primary care practice. I'd like to tell you a little bit about the Women's Health Initiative at St. Francis in Trinity, and then we'll start in with the headache webinar. Could you just quick reminders, please make sure that you're on mute. And if you have any questions, please put it in the chat feature. We will have some time, hopefully at the end, to get to all your questions. And this session will be recorded and placed on our website for further evaluation. So we have a very unique system at St. Francis as well as at the Trinity system. We have our Women's Health Concierge program. There is a nurse who can be reached at 1-833-NE-WOMEN, who can help you with any questions you have about your health or medical conditions. She can help you get set up with a multitude of different practitioners as well as subspecialists. She's a nurse navigator and she's really wonderful. So you can call her directly with any questions or to help get set up with an appointment for any of the subspecialists, including the neurologist that you'll see and hear from tonight. So please consider talking to our Women's Health Concierge at 1-833-NE-WOMEN. Part of the services that are offered through Trinity Health of New England, as well as through the Women's Health Initiative, are some of the subspecialists you see here. We have been very diligent over the past year and a half to put together multi-specialty and multidisciplinary approaches to women's healthcare. Some of it you'll hear tonight about the headache clinic that we started for women. Multitude of different organizations are working within the subspecialty, especially with neurologists tonight. You'll hear from them. They'll tell you how they work with the integrative medicine as well as physical therapists and nutritionists to help their female patients out with chronic headaches, migraines, acute headaches, etc. So please pay attention. If you have any questions, again, you can contact us. We'll give you our information, as well as you can contact the neurologist directly, and we'll give you that contact information toward the end. I would just like to briefly introduce Dr. Kumar and Dr. Sater, who are our speakers tonight. They run the the Women's Health Initiative Headache Clinic at St. Francis. Just to let you know, Dr. Kumar is a neurologist and an epileptologist, I hope I got it right, at St. Francis, as well as in Waterbury at St. Mary's Hospital. His area of expertise, in addition to running the headache clinic, is epilepsy. He provides epilepsy and EEG services at St. Mary's as well as St. Francis. Dr. Sater is a neurologist and pain management specialist. He joined Trinity about a year ago and is an attending and provides excellent care in pain management as well as in headaches. So Dr. Kumar will be our first speaker, and then Dr. Sater will follow up shortly thereafter.
Thank you, Lisa. Very excited to be here. Welcome, everyone. Let me share my screen. All right. My slides. Lisa, can you see my slides?
Yes.
Perfect. All right. So welcome, everyone. Today we'll be discussing, I'll do the first part of the talk and Dr. Sater will follow me. I'll focus on various types of headaches, medication management, basic management, and what we do here at St. Francis Headache Clinic. Dr. Sater will focus more on procedures, various types of techniques he uses, and also some medications. When we talk about headaches, we divide headaches into primary and secondary. When we look at primary, let me get one more thing here, presentation mode, give me 1 second. All right. In primary headaches, we have different subcategories. Migraine is a big one, tension headache. We have other types. In secondary, when we say secondary headache, it's usually something as a consequence of something different happening in the brain, usually a bleed or a tumor or a lesion. So that goes and falls under secondary headaches. Looking at primary headaches, migraine headache, I put this slide to show the prevalence and also to look at women's and a ratio of males to females. Migraine predominantly in women 10 to 16%, tension headaches as we see a lot of these patients in the clinic here, up to 59%, which is episodic. And the other big chunk is exertional headaches, which is up to 30%. Rest of the headaches is, I know, very rare. We do see once in a while, but majority usually goes under migraine or tension or exertional headaches. Looking at migraines, um, blue we have prevalence in men, and red we have it in for women, and we have subdivided into age. Usually migraines we start seeing in teenage, increases in 20s, and then further more in 30s. And then we gradually see some tapering down in prevalence, or when patients start having these migraine headaches. And looking at the location, we have sinus headaches, and as I show here in the picture, the location of the headaches varies with the type of headache. Sinus headache usually surrounding your sinuses. Tension headache feels like a band. Tightness sensation over the forehead. Migraines usually one-sided, right or left. It can go either ways, but usually one stays on one side. And cluster usually surrounding the eyes. And we do see some overlapping symptoms between different types of headaches. Um, as I have shown it here, migraine and tension and cluster headaches, we do see some overlap. On tension type, we'll focus next couple of minutes to discuss and look at tension type of headaches, which is one of the most common headaches what we see here in the clinic. Cause is what we say sensitization of pain receptors, myofascial, which is a combination of muscles and fascia, which increases the sensitivity of this pain pathway in the brain. Medication wise, we have two different varieties. Or we say when we have a headache, if we give a pain medication, the headache goes away. We call them abortive medications or acute medications. If headaches are happening a lot, more than 15 days a month, we use preventative medication, which you take every day with or without headaches. And that helps control the frequency of headaches. We're not going to go into details of different types and names of medications, but just to bring some information to you guys and for awareness, um, we do have prophylactic treatment, as I just said, and we have three different classes: antidepressants, anti-seizure medications, and sometimes combination of muscle relaxants and antidepressant medications. We tend to pick one class of medication and go to the next one if a patient fails that class of medication. For tension type of headaches, we do have behavioral therapies. We talk to patients on sleep, exercise, meals, refer them for therapies such as cognitive behavior therapy, some biofeedback, relaxation techniques, many times, usually combinations of the above. When we look at non-pharmacological, or when patients say not very keen on medications, or medications are not working, or even when we start one medication, we usually um, have our patients go through some non-pharmacological therapies. Acupuncture is a big one for us, physical therapies, especially neck exercises, massage therapies, and few other techniques. Medication overuse headaches. Um, we do see a lot of patients, they start having a type of headache, either migraine headaches or tension headaches or cluster headaches, and they tend to overdo the pain medications, over the counter medications. If they cross more than 10 days per month, in a span of 3 months, they tend to have what we call medication overuse headaches. It's pretty much the body is used to these medications, If you don't take these medications, you'll have a rebound headache. And it's a vicious cycle. And this is what we call medication overuse headaches. It's very common to see patients taking a medication by name Fioricet, which is a combination pill, and also over-the-counter Aleve, Tylenol, um, or some combination medications. What we do usually when we see such patients is we start a prophylactic medication and slowly and gradually taper off their over-the-counter pain medication. Migraine headaches, we'll focus next 5 minutes on migraine headaches. Very common in women. We do divide migraine headaches into episodic, less than 15 days a month, a chronic, more than 15 days a month. Usually these headaches are disabling. They have throbbing type of headaches associated with nausea and light sensitivity, sound sensitivity. A lot of our patients have familial history, headaches in mothers, or cousins. And many times, around 25% of people, patients with migraines, they have aura, usually flashing lights, bright spots, zigzag lines, sometimes numbness or tingling in the fingers, very rarely motor or weakness on one side of the body. Why do we see migraines very commonly in women? Uh, we looked into these studies. There are many studies talking about why as a reason, and they all say hormones. Estrogen, which is one of the hormone, fluctuates, especially with the menstrual cycle. So whenever estrogen drops, women tend to have a migraine headache. And after giving birth, before menopause, during menopause, after, it's very common whenever there's a sudden drop in estrogen. And further treatment wise, we can talk a little bit more at the end of this talk, but we do have a different approach when we see women with menstrual migraines. Triggers for the migraine headaches, especially emotional stress is a big one, 80% anxiety. When a patient is anxious, they don't sleep well, the heat, the food is not healthy, the sleep is disrupted, that can trigger a migraine. Brightness from your computer screen can trigger a migraine, noise or sound, as we just mentioned, sleeping habits, eating habits. Physical activity, overexertion is one of the big ones. Lack of physical activity can trigger a migraine. Food is also a big one. We look into this very carefully. We usually have a conversation with our patients to discuss the food which can trigger the migraine. Caffeine, chocolate, wine, uh, artificial sweeteners can trigger migraine headaches. Dehydration, and many patients report change in weather, humidity can trigger a migraine headache. We're not going to go into the complexity of pathology of migraine, but to keep it simple for our audience, um, the reason for a migraine is activation of trigeminal, which is the fifth nerve on the face, and the vascular blood vessels, right, surrounding those nerve endings. They're overactivated, and that releases these red dots, which is CGRP chemicals, neurotransmitters, what we call substance P, CGRP. They cause dilatation of blood vessels, and it's a cascade of events, but triggers in dilatation of blood vessels, causing pain and migraine symptoms. Again, for migraine treatment, we divide the treatment options into acute or abortive treatment and preventative. Depends on how many headache days a patient has per month. For acute treatment, we have multiple options: NSAID, triptans, gpans. These are newer ones. Uh, we are using these medications a lot compared to the older medications, um, just because side effect profiles and long-term use, we look into that. When we are looking at preventative medication, which helps to control the frequency of headaches, you start taking these pills every single day, and we see some reduction. We see a lot of reduction in headache days. And we do have different classes where we pick medications from. Antidepressants, we have a bunch of medications. In antidepressants, anti-seizure medications, and beta blockers, we pick the medication which is appropriate for particular patient. Botox is, we've been using Botox for quite some time now. Um, we are seeing very good results here. It's a toxin, botulinum toxin, which again, the mechanism is complex. But to keep it simple, what it does is it inhibits the sensory nerve endings. Wherever we see the darts, we inject 1 cc of the solution or Botox, and it has multiple ways to help reduce the frequency of migraine headaches, but predominantly inhibiting the nerve endings, and with that, they block the pain signals to reach the brain and also to inactivate the muscles. We do have newer techniques, newer treatment modalities. CGRP is the chemical or neurotransmitter which we just looked at. There are blockers for these CGRP chemicals or receptors, what we call CGRP antagonist. We do have different companies and different type of these injections available monthly. It can go up to once every 3 months. Um, Botox, we do it every 3 months, every 12 weeks. Other options to treat migraine headaches, we use acupuncture, nutrition, um, especially magnesium, vitamin D, riboflavin. We use this a lot. Trigger point injections help. Neuromodulation, we don't use this a lot, but I wanted to have it here to show these are potential options too for a few patients. Um, we have a device called Cephali, which is transcutaneous supraorbital nerve stimulator, stimulates the nerve on the face. It can be used for both acute migraines and also to prevent headaches in the future. Um, the response or success is not too high, maybe 38 to 40%. We do have transcranial magnetic stimulation, again, which sends a magnetic pulse to stop the pain. We do have vagal nerve stimulator. It's a device, you hold it in the hand, especially for acute treatment of headaches. Migraine headache. I want, for sake of completion, we do say, I have the slide here, cluster headache is not very common. We see in our practice, in our clinic. Um, it's seen more, prevalence-wise, it's more in men compared to women. There is some association with smoking. Pain is severe. Our patients are restless. There is excessive tearing from an eye, usually one-sided, redness on the eye, one-sided, stuffy nose, can occur multiple times per day, and the treatment modality is different as compared to migraine headaches. I think with that, I'll hand over to Dr. Seder.
Hello, everyone. Lisa, can you hear me?
Yes, but I can't see your slides.
Me neither. I can see them now, but I can't actually click through them.
I'm working on it.
Sure. Or I can just ask you to move forward to the next slide if you want.
Dr. Sater, do you want to begin while they're getting the slides sort of prepped?
Sure. Okay, so hi everyone. My name is Eli, and I'm going to be talking a little bit more about the procedural aspect of headache and chronic pain treatment. So if we can move forward to the next slide.
Dr. Sater, you should have control to
Let's see.
go to the next one now.
Yes.
There we go.
Okay, excellent. All right, so I'm a very visual person, and there's going to be a lot of neuroanatomy diagrams and photos in the talk. So for anybody who has had anatomy before, there's going to be flashbacks, and it might be a little complicated, but it's going to help us all understand the anatomy of headaches and also why the treatments work. I won't go into too much detail about the anatomy, but it really just helps to have a picture of what's going on. So why don't we start with disclosures? No financial disclosures. None of the companies for migraine medications are paying me any money. So if I talk about a medication, it won't really be due to any financial incentive. I will be talking about Botox, and sometimes I say the word Botox, even though referring to botulinum toxin in general, and there's other companies that make Botox. So they're really interchangeable, but keep that in mind. And I will be talking about some off-label uses of medications and also procedures in the stock. So that they may not be FDA approved, but clinically, a lot of clinicians use them. And so I would just keep that in mind for all the cases we're going to be discussing. Dr. Weisinger already introduced me, but just a quick reminder, I have dual training in neurology and interventional pain, which is probably why my focus is a little bit more procedural, but I include medications and non-interventional therapies in my regimen too. All right, so let's start with the first case. We will be discussing a patient. We're going to call her Angelique. She's 43 years old, and she has been having headaches for more than 20 years, which is a very common case that I get in clinic basically every day. And per Angelique, her headaches are behind her eyes, so retroorbital. She does have a occipital component, so she feels that maybe the back of her head and her neck hurt her sometimes. Depending on the day, some of the headaches are on both sides, some of the headaches are only on one side. She has an overall 20 days of headache per month, but only 10 of those days are actually severe and associated with throbbing, a pulsating sensation, some nausea, maybe vomiting, and sensitivity to light. She takes Imitrex, which is one of the common rescue medications we use for headaches, 15 times a month, and it doesn't really stop her headaches. And she still has a headache the same day and the next day. She has tried multiple preventive medications like Topamax, propranolol, amitriptyline, and none of them have helped. She has an MRI brain that was already done, and this is very common. I see patients who already had a brain MRI and have already been evaluated by multiple neurologists or pain doctors. And so they had the workup done, but it was all negative. And basically nothing really on exam. And basically, she's coming in to see me. So what would we do for Angelique? There's multiple options. One option is we start her on a medication, which is one of the newer medications for migraine. It's called Nurtec. It's one of the CGRP antagonists that Dr. Kumar mentioned in his talk. And that's one of the options, considering that she's already tried the classic medications and failed them before. Another option is to refer for Botox injections or for occipital nerve blocks. Or simply to have her cut down on the sumatriptan she's using because it's not really supposed to be 15 times a month. So all those are reasonable options, but we're going to be discussing a few things that might be better options than others. So one thing I want to point out, first of all, is that a lot of people seem to confuse tension headaches with migraine headaches and with the diagnostic entity of chronic migraine. And this is potentially because of the classification of headaches that we have as part of the ICHD. But the idea really is that sometimes people assume that if it's a headache in the front on both right and left, that's just a tension headache. And then if it's a headache only on one side, then it's going to be more of a migraine headache. And that's a reasonable assumption, but it really gets a little trickier when we talk about episodic migraine versus chronic migraine. And based on my clinical experience so far, the most common thing that I see is actually chronic migraine, which is a mix of both episodic migraine and tension headaches. And that's really common. A lot of patients get confused because they're trying to put themselves in a box and say, okay, I'm dealing with tension headaches or I'm dealing with migraines, when it's actually both. And that's why the entity itself is actually called chronic migraine. So something to just keep in mind. And then the other misconception that I wanted to point out is that a lot of people have neck pain, upper back pain, and occipital headaches. And then clinicians don't really make the association between that and the headaches that they are getting behind their eyes or in their forehead or even in the temples. So a lot of people think that if you have a headache behind your eyes, then that tends to be a different etiology or cause than a headache that is at the back of your head or your neck, when it can actually be due to the same entity. And this is where the phenomenon of referred pain comes into play, because a lot of patients will have neck pain, upper back pain, and therefore impingement of an occipital nerve, which I'm going to show in the next slide. And then that will lead to referred pain behind the eyes or referred pain in the temples. And that gets missed and then mistreated as far as what is done about it. This is what the diagram shows. All right, so and the reason for that referred pain is really because in the middle of the brain, in the brainstem, there's an entity called the trigeminal cervical ganglion, where basically there are connections between the occipital nerve, which is coming from the neck, and the trigeminal nerve, which is innervating the envelope around the brain, the dura, and also innervating the face. So when there's a connection in the middle of the brain, that creates the possibility of referred pain. The same way why people who have a heart attack or chest pain can have arm pain in the left arm at the same time. It's the same principle of referred pain. So the idea is essentially that the occipital nerve and the neck would be referring pain onto the area of the head that is essentially behind the eyes. So something to keep in mind because it can be misleading for a lot of people. When I think about pain interventions, whenever I'm seeing a patient, I usually offer them a continuum of options. And that continuum spans from conservative management, and that's a lot of the things that Dr. Kumar mentioned, like acupuncture, massage, and physical therapy, which is always reasonable to try. And then medical options. So that includes the classic medications we have for headache, whether we're talking about prophylactic medications or we're talking about rescue medications. So all those are reasonable. And then there's the procedural options, which I'm going to be discussing in a little bit. And then, at the very end of the continuum, you have surgery for some conditions. Obviously, not an option for all conditions, but for select few conditions. And I leave it usually up to the patient. I like to have a discussion with the patient and try to see what do they prefer. I have patients who will tell me, I don't want to be taking a medication every day for the rest of my life. I prefer to have a procedure if that procedure potentially can take away the pain for 3 months or 6 months at a time. And it means I don't have to take a medication daily. But then I have also patients who tell me that they don't like needles and they prefer to try medications first. And both are reasonable approaches, but that's why I like to tailor it to what the patient wants and have a conversation about the risk and benefit of every option. I want to point out this app on iPhone and probably other smartphones called Migraine Buddy. I believe it's free, but there may be some purchase options within the app. But I usually recommend it to my patients because it helps you identify triggers. And also it gives you data on your headache. So whenever you have a headache, you can log it in that app, and then it will ask you and prompt you to identify triggers for it. So it will ask you, have you had any caffeine, or have you had any wine, things like that. So and it will also ask you about where the pain is and where the headache is on your head and neck. So as you can see in the slide over here, it gives you data at the end of the month as to how many days of headache you had, what are the triggers that you may not even be aware of, and that can potentially help with your treatment to be able to avoid those triggers and see if you're responding or not to a given medication or intervention. All right, so a few slides on occipital nerve block, which is one of the more common procedures that I do for headache. So anatomy of the occipital nerve. This is an image of the head and neck looking from the back. And essentially you see that from the cervical spine, you have a nerve that emerges around C2 and C3, and then it goes at the back of the head. And it splits into 2 or 3 branches. So there's 2 major branches, really. One of them is called the greater occipital nerve that you see right here, that I'm highlighting with my cursor. And then you have the lesser occipital nerve, which is a little bit closer to the ear. And these are really important nerves that not only innervate the scalp, but also the envelope around the brain in an indirect way, like I mentioned earlier with the trigeminal-cervical ganglion. And the way to do the block, there's 2 different ways. And one way is really to do it at the nuchal ligament. And that's really the classic way that has been done for many, many years. And that is potentially less invasive and easier to do by a lot of different people. However, it tends to be less effective than the more advanced modern block that is done with ultrasound guidance. That is basically displayed with B over here at the level of the C1 and C2, essentially, because you're targeting the actual root of the nerve as opposed to the more distal component. But in terms of doing the block, a lot of clinicians do it in the office. And you can do it based on anatomical landmarks by palpating the mastoid, the occipital protuberance, and then going 1/3 of the way, essentially, for each of the 2 branches of the nerve. And we normally inject a mix of local anesthetic like lidocaine or bupivacaine, as well as a steroid. And the idea behind it is that the local anesthetic is going to act the same day and provide pain relief, whereas the cortisone is going to start working within a few days, but it will give a longer lasting relief, usually for 3 months or more. And the image over here is basically showing the more ultrasound guided modern block, which I'm going to be showing in a little bit. This is just an ultrasound image from my office on a patient where I was doing the block. This is the distal block that is at the level of the skull, the nuchal ligament. So you can see over here, the white line is actually the skull. And then above it, you see in red the occipital artery itself, which we use as a landmark for where the nerve is. And then you see the needle over here that is basically going down and then basically hitting the periosteum, so hitting the bone. And then we just retract it a little bit where the nerve and the artery are, and then we inject the actual medication. So that makes it more precise. This is an image over here taken from a paper in the British Journal of Anesthesia. And basically it's showing the more modern block where we do the block at the level of C1, C2. So it's really in the neck, at the base of the head and at the interface between the head and neck. And this is where the nerve itself arises. And there are several muscle landmarks we use for it, and we can actually see the nerve itself when we do it here. And we inject, and that tends to be significantly more effective and reliable based on that study and future studies that also showed the same thing, that basically when we block it at that level, it tends to be between 95 and 99% effective, as opposed to doing it distally at the nuchal ligament, where we're assuming that the nerve is going to be at the anatomical landmark, but we can't see it. This is an image from one of my patients. You can see the needle right here going down at the interface of the inferior oblique and the semispinalis muscle. And essentially, this is where the nerve is, and we are injecting the mix right there. And this is just the diagram showing essentially where the nerve is on that specific image. So what do we use the occipital nerve block for? Different things. There's actually a lot of indications for an occipital nerve block. And potentially one of the more common indications is migraine. However, it's classically used for occipital neuralgia, which is really pain at the head and neck that is emanating from the occipital nerve that may not fulfill criteria for migraine. But it can also be used for tension type headaches, for chronic migraine, like I mentioned earlier. It's FDA level A evidence approved for cluster headaches, especially when steroid is on board. So that can be very useful, which makes sense if we think about it, considering that cluster headaches involve the eye and the retroorbital space quite a bit. And so blocking the occipital nerve, which is giving referred pain to the eye, is extremely beneficial for those patients. And it's useful also for trigeminal autonomic cephalalgias and a lot of other kinds of head and neck pains. So this is a paper, one of many papers that showed benefit of the occipital nerve block. Essentially, if you look at the diagram, you'll see that before the treatment, the patient was having, let's say, on average, 20 days of headache a month. And then a month later after the procedure, in the group that received the bupivacaine, there was almost a 50% reduction. And several other studies. This is just a mix of all the different studies that were done on the occipital nerve block in the realm of chronic migraine, in the realm of acute treatment for migraine, cluster headaches, as well as in pregnancy for one of the studies. And essentially, all of the studies were positive and showed evidence for a lot of benefit. And the references are included over here. I won't go into the details, given the time constraints we have. Suffice it to say that there's a lot of evidence for occipital nerve block, both for chronic migraine treatment, in other words, for prophylaxis to prevent them from happening in the first place, but also for acute treatment in the emergency room or in an urgent care setting, where we can do the block if a patient is having an acute headache, and that will usually help the patient quite a bit. All right, so let's switch gears and talk about Botox for chronic migraine. This is another one of the treatments we use. And if you look at this timeline, this is basically showing the FDA approval dates and years for Botox. So the initial indication for it that was FDA approved was blepharospasm, which is uncontrollable blinking of the eyelids. And that was in 1989. And then there was cervical dystonia and other indications. Chronic migraine itself was in 2010, FDA approved, and we've been using it since. And it's showing a lot of benefit and promise for patients. This is a table showing and reminding you that there's more than one type of botulinum toxin. So you have Botox A, B, and then other forms. The one we are usually using the most often in chronic migraine is Botox A. So that's just something to keep in mind. Other Botoxes can be used, but Botox A tends to be the most commonly used one in studies that replicated the benefit in chronic migraine patients. So Dr. Kumar touched on this a little bit. I'm going to expand on the mechanism of why Botox works. The first time I used Botox when I was in residency and fellowship, I started questioning, why is it that we're using a muscle paralysis toxin to help somebody who's having a headache? It didn't make sense to me. So I had to look it up to understand the mechanism for it. So there are three major ways that Botox uses essentially to help clinically. One of them is muscle paralysis. And if you look at this slide right here, this is really the more common way that people think of Botox. The toxin itself will go in and cleave the snare proteins essentially in the neuron, so preventing the release of a given ACH, acetylcholine, into the neuromuscular junction. And when that happens, you have paralysis really of the muscle. And that's really the mechanism that is at play when we're discussing spasticity, cervical dystonia, and things of that sort. Another mechanism that Botox uses is really inhibition of secretion. And that tends to be applicable to hyperhidrosis, so excessive sweating, and other conditions. This is a paper that I published a couple of years ago in Boston on a patient of mine who was having sweating in her face every time she eats. And so it's called gustatory sweating, also known as Frey syndrome. And basically, we used Botox on her cheek in this distribution over here to prevent that sweating from happening. And then the third way that is probably the most relevant for our conversation today is really muscle inhibition of the sensory afferents around the muscles of headache. So basically, the Botox is going to go retrograde. So it's going to go backward into the neuron, into the spinal cord, and it's going to decrease the release of the inflammatory mediators of pain, which are CGRP, glutamate, and substance P. And that tends to be the most common mechanism as to why Botox helps with headache and other chronic pain conditions. But another one is really the muscle component, because you're relaxing the muscles that are tugging on the nerves, such as the trigeminal nerve and the occipital nerve. So it's really a dual mechanism in this case. The preempt study and protocol is really what we use clinically for patients with chronic migraine. And that's really the landmark study that showed a decrease by about 60% in terms of number of headache days for patients who were treated with Botox. This is really the landmark study that everybody references. It is notorious for leading to a pretty significant placebo effect, because essentially in patients who received saline injections instead of Botox, they still had a remarkable decrease in the number of headache days. Not significant, like in the Botox group, but reasonable. And I suspect that part of it is because you're essentially doing a trigger point in those muscles when you're doing the injection. So that itself helps. And then this was followed by something called the COMPEL trial, which really followed patients for a much longer period of time and proved that there was benefit in terms of the reduction of their headache days that was sustained and also increased with time. The protocol itself is pretty straightforward. The whole procedure takes 2 minutes. It's 31 different injections with an extremely tiny needle, and it goes in different spots in the head and neck. And there's a specific protocol that everybody uses for it to make sure we have consistent results. Side effects are very limited. The most commonly cited side effects in the literature are neck pain and muscle weakness, especially in the neck. I've never had that. I think it's something that can be avoided with proper technique. Rash and other allergic reactions, extremely uncommon, but something that has been reported as well. The one thing that does happen potentially a little bit more commonly would be cosmetic effects. So something we call Spock eyes, and that really is displayed in this picture over here. And it tends to happen when the injection into the corrugators is leading to paralysis on that side, but then you still have frontalis working over here. So the eyebrow is really raising on this side, the lateral aspect, but not the medial aspect. However, that itself can be prevented as well, and we can do the injection in a way that does not lead to any kind of cosmetic problems afterward. All right, so going back to Angelique, our patient. After every single procedure that we do in my clinic, we have our pain nurse, Stephanie, who is excellent, and then we have also medical assistants who are really all part of the team and very invested in the care of our patients. They call the patient the day after or 2 days after to check on the patient. And so in this case, Angelique was doing so much better, and she was headache-free for several days and weeks actually after her procedure, as per the telephone note from when they called her. All right, so the next case is going to be Sarah. So Sarah's 27. She has never had a headache before. And essentially, I saw her on the inpatient side. She was admitted to the hospital, and she delivered her baby. And then a few days later, she had a spinal headache due to low pressure and a CSF leak, presumably from her epidural, which was potentially a spinal in that case. And so she was bedridden and unable to move from her bed, because every time she moved, she would have a bad headache. And again, she never really had those before. They did a blood patch for her before consulting me, and despite the blood patch, she was still getting bad headaches and not able to care for her baby and not able to move around. So she was basically in the hospital for a good 7 days, and they weren't really able to discharge her home, unfortunately. Her MRI brain showed evidence of low pressure headaches with pachymeningeal enhancement. And on exam, she didn't have anything focal. So what do we do for Sarah? So a few options. We can give her a migraine cocktail, which is essentially a mix of different medications we give for acute headaches, IV. And that's a reasonable option, except that for her, it didn't really help. We can do an occipital nerve block, or we can do an SPG block, or we can repeat the blood patch. So I'm going to talk about that now. What is what is happening here. So this is a paper that I published a couple of years ago on headache in pregnancy and postpartum as well. And one thing to keep in mind is that in pregnancy itself, there's a lot of caveats in terms of medications we cannot use, which would be harmful to the fetus. So we used to have FDA pregnancy categories that were eliminated, I think, around 2016, but we still use them because they were pretty useful. And certain medications like Topamax, which is very commonly used for headaches, is category D. So that means it's really harmful and not recommended for use in pregnancy. And some of them, like the valproic acid or Depakote, is absolutely contraindicated. So there's limitations, and that's why we need to have safer options. SPG block. So SPG stands for sphenopalatine ganglion. And it's really this tiny structure that is between the nose and the throat. And it's really 6 millimeters in diameter. And for those who have studied anatomy before, you will probably have flashbacks to the pterygopalatine fossa and its very intricate anatomy. And the reason why I'm bringing this up is because the SPG ganglion is really like a hub. It's essentially like an airport where a lot of different things are landing. And it's connected to the trigeminal nerves. It's connected to the occipital nerve. It's connected to everything essentially, and that makes it a great target for head and neck pain. So this is another diagram showing all those connections between the ganglion and the different branches of the trigeminal nerve and the autonomic nerves as well. The block itself can be done in different ways. So this is one of the more traditional approaches where we go under the zygoma, essentially, but that tends to be the riskier approach. The one that I do is through the nose, and that's the one that has been proven to be the safest and the easiest as well as far as access. So it's really a matter of going in with a catheter in the nose and then finding the correct turbinate where we want to inject the lidocaine, and then the lidocaine will diffuse through the nasal mucosa and go to the ganglion and stop the headache. This is another diagram showing the same thing. Multiple studies, old studies and kind of more recent studies. This one is from Pain Physician in 2020, showing the benefit in 386 patients who had SPG blocks for acute headaches. And basically 94% or so of those patients had improvement on the spot. This is another study showing really the timeline. If you look at it, so from the moment that they did the procedure for those patients, they were checking on the pain score. So the pain score was 7 out of 10, before the procedure, and then 15 minutes after the procedure, it went down to 1. And this is average across, let's say, 50 or 100 patients in the study. And then it remained low at 1 throughout the day and potentially for the week for several patients. When the patients were asked about their improvement in that study, at 2 hours and also at 24 hours, the majority, so 75% and 69%, reported very good improvement in terms of their pain score, and basically nobody had any adverse events. The most common thing I warn my patients about when I'm doing an SPG block is that they will feel a little bit of a throat numbness and a bitter taste from the lidocaine itself. Because like I said earlier with the anatomy slides, it's at the interface of the nose and the throat. So when we inject the lidocaine, some of it will go to the throat a little bit and give that bitter sensation. But it's not anything that bothers patients. And as long as they expect it and they see it coming, it doesn't bother them. All right, so Sarah's story, she basically, I did a combined SPG block with an occipital nerve block for her that day. And then per the nursing notes, within a couple of hours, her pain, she was pain-free essentially. And then she was able to stand up, she was able to hold her baby, and then she was discharged that same day. All right, our last case for today is going to be Debbie. So Debbie is 53 years old, and she has been having facial pain on the right side for about 10 years. And she has a diagnosis of trigeminal neuralgia, which is an extremely painful facial pain condition that is notoriously difficult to treat. And she's already tried the classic treatments like carbamazepine. They even did cyberknife surgery for her, which did not help. And then she had multiple other procedures, and she didn't get any benefit from those. So what are we going to do for Debbie? We can give her IV Dilantin, phenytoin, as a loading dose to help her with the acute pain component. That's a reasonable option. And then we can do trigeminal branch nerve blocks We can schedule for Botox injections. We can switch her to another anti-epileptic medication, Trileptal, which is a newer version of carbamazepine. So all those are reasonable options, but I want to discuss very specifically the trigeminal branch nerve blocks. So what are these blocks? If you look at the diagram over here, you will see that the trigeminal nerve, which innervates the face and receives sensory input from the face, you have three major components to it. One of them is really more the forehead and the eye, and then you have the part that is in the cheek below the eye, and then you have the mandibular part. And what we can do is, depending on the location of the patient's pain, we can target those specific nerves. So what I did for Debbie, for example, is I specifically blocked her supraorbital nerve and her infraorbital nerve, because that's really where the pain was for her. And this is just an image showing what the block looks like. And again, it's a mix of a local anesthetic and a cortisone shot. So similar to the occipital nerve block and many other nerve blocks, it tends to be a common theme. This is another image. It's just showing the various the parts of the trigeminal nerve. So really, this one over here is a supraorbital nerve for people who have pain in their forehead. This one over here is for the more mental nerve block, which is mandibular pain. And then this one is in the cheek, so the infraorbital nerve. Just showing the various examples of what we can do. So for Debbie, I did trigeminal branch blocks, and she did great. Based on the phone encounter that she had with our excellent pain nurse, Stephanie, it seems like this was the first time that she was pain-free in many years. And she had even had suicidal attempts in her past due to how severe the pain was. So that was Debbie's story. This is a summary of the blocks I presented so far, just essentially telling you that the occipital nerve block can be used both for chronic headaches and for acute headache therapy. You can do it once, or you can do it every 3 months, depending on the patient's pain. I have a few patients who had excellent relief with their procedure, and then after 4 months, let's say, they call me and they say, okay, we feel the headaches are coming back now. Can we get another block? And so we bring them in and then do another block, which just takes 5 minutes. And then Botox can be used for chronic, but it's really not something you can use for acute, because Botox takes at least 3 days to start working. So it's not something you can do in an acute pain situation for anything really. And it has to be done every 3 months. SPG blocks are mostly for acute treatment. So something that we have been offering in my pain clinic now is acute treatment for headache and for other kinds of pain. So given that we have our excellent pain nurse, Stephanie, something we can do is IV medication. So let's say a patient comes in with an acute flare of their headache or their pain. We give them an IV, and then we can give them the same medications they would receive in the emergency room, except that they don't have to wait for hours in the emergency room. They can just show up to our clinic and we do it on the spot. And I tend to combine that with an SPG block. And then usually by the time we're done with the whole procedure, so essentially 10 minutes for the combined cocktail and also the SPG block, the patient is pain-free. And then they leave and they're extremely happy most often. Trigeminal branch blocks are done for facial pain mostly, and they tend to be more of an acute intervention. There is a more chronic version of it, but we don't use it as often, but that would be radiofrequency ablation. All right, I'm almost done. This is just going to be the last couple of minutes. So in addition to treating headache and facial pain, which essentially is about 50% of my practice, I also treat other chronic pain conditions. So this is definitely a lot of material for another talk. If there is interest, I'd be happy to give a talk on those topics. But just a quick teaser for those. So patients with carpal tunnel syndrome who have pain in their wrist, numbness, tingling in their hand, we do carpal tunnel blocks for those patients under ultrasound guidance. So you can see over here in this image, this over here is your median nerve that's giving all those pains and paresthesias. And this is my needle going in under ultrasound guidance right under the nerve and injecting the cortisone to help relieve the pain. This is an example of an epidural steroid injection. So for patients who have sciatica and back pain that is going down one leg, for example, I use fluoroscopic guidance, and then I can visualize the spine and then inject the cortisone in those areas. other kinds of back pain procedures that tend to be more axial back pain. So for somebody who's having pain in their back but not shooting down the legs, facet joint procedures are usually the best ones. So that's really for the patient who is having back pain when they are standing or when they are walking, and that is relieved when they are in flexion mode. In other words, when they sit or when they lean forward. So we do facet blocks, medial branch blocks, radiofrequency ablations for those patients. Stellate ganglion blocks with its many indications that range anywhere from CRPS to head and neck pain and also even PTSD. So we do those as well under ultrasound guidance. And this one over here is for joint injections. So I do a lot of those. So shoulder injections, hip injections, knee injections. This one particularly is an example of one of my knee injections from the past week, where basically we go in under fluoroscopic guidance and you can visualize the joint line. I go in with my needle, I inject dye to make sure I'm actually inside the joint space, and then I inject the medication. And the whole thing is done in 5 minutes and tends to provide instant relief for patients who don't want to get surgery, let's say, or who want a temporizing measure. Pudendal blocks, so very relevant for our audience. So this is more common for pelvic pain. So that's definitely something that I do for patients who have pelvic pain. This is the needle over here going at the ischial tuberosity and then injecting the cortisone for a patient with this kind of pain. That's all I have. Thank you for listening, and please let us know if you have questions.
Thank you, Drs. Kumar and Dr. Sater. This is Dr. Weisinger again. I have a few questions for both doctors this evening to ask. To start off, I think is a very common question. One of the participants asked, I get bad headaches when I go a day without caffeine. Is there anything I can do to fix this that doesn't involve giving up coffee? Or in my case, Diet Pepsi?
I can go for this one. It's difficult to not decreasing caffeine intake or coffee intake and getting rid of the headaches. This is very well known. It's called caffeine-induced headaches or withdrawal headaches, rather caffeine withdrawal headaches, where coffee or caffeine is known to constrict the blood vessels. And if you're used to it for weeks and you don't take coffee, then you'll have bad headaches. We need to look into why you're having headaches and try to treat those, and also cut down a little bit of headaches by coffee intake. So that needs a visit to neurologist.
Wonderful. So there's another question here saying, are nerve blocks and Botox injections covered by most medical insurances?
So yes, the only insurance I run into problems with tends to be Blue Cross Blue Shield, and that's very selectively for some of the nerve blocks because they're not necessarily up to date on the most recent evidence. But a lot of times we end up going around it by having what we call a peer-to-peer with the insurance company. And across all the many patients that I've had, let's say, to give an average, 100 procedures over the past month, not a single one were we unable to approve the procedure for. So there's always ways we can do to advocate for our patients and make sure they get the procedure that they need.
Wonderful. You mentioned, I think Dr. Kumar mentioned some of the food triggers. Can you sort of run through that really quickly again?
Yeah, so there's a lot of, well, that's a big discussion, but very commonly what we see is wine, chocolates, artificial sweeteners can trigger migraines. There are many, but those are the common ones. So as Dr. Sater just showed, the diary or having an app on the phone, try to retroactively look at what might have triggered that migraine headache, and avoiding those type of foods can help at least get rid of few of your headaches per month.
Wonderful. You did mention also about severe headaches during menstrual cycle. Can you touch on that again? Either one of you.
Yeah, sure. I had this on my slides. It's very oftenly we see this in a woman. This is because the drop in estrogen just before their cycle. We do have a couple of different modalities of treatments. Most commonly, what we use is a medication which you start 2 days before your cycle and continue for 3 to 4 days. So total of 5 to 6 days. You'll have to use that during your cycle.
Does long-term headache pain change the pain chemicals in the brain to lower pain tolerance?
I can go to Sarah. You want to go?
Sure. I mean, basically, there's definitely studies showing changes in plasticity in the brain for people who have chronic pain in general, but specifically in this case, chronic migraine. And those changes tend to be at the level of the pons and the hypothalamus, based on most of the fMRI studies. And there's a lot of changes in neurochemistry that happen with serotonin and dopamine. However, what is very important to this conversation is basically asking the question, if somebody has chronic episodic headaches, let's say 5-10 headaches in a month consistently over time, is that going to lead to chronic headaches and just make things worse, in addition to lowering the pain threshold? And that is really up for debate. I don't think anybody knows the answer to that yet. There's association studies, but nobody has proved that it's actually going to lead to that. So there are changes essentially, but no one really knows if it's a cause or not.
So Dr. Kumar, I think, mentioned that the migraine headaches tend to start in the teenage years. If there is an individual who has a teenager who suffers from migraine headaches, where would they start to look for some relief?
Right. So I think the first point is going to be seeing a neurologist, looking at what type of headache or is it a migraine diagnosis is important. Once we have the right diagnosis, we look into how many days per month that particular patient has headaches, and we take it from there. Depending on how many days, we have various different modalities of treatments.
And what age do you start in your practice?
We start at 16.
16. Okay, so that's really a great introduction for those individuals who have children who have migraine headaches. Here's an interesting question. I use marijuana recreationally for my migraines and it helps a lot. Do migraines qualify for a medical card?
So interesting question. And answer is not very simple though. So Connecticut DPS, Department of Public Health, does list marijuana, medical marijuana, as an option, or it's allowed for intractable headaches. They don't say migraines, but they say intractable headaches, which means you should have tried multiple medications and you should have failed those medications and still continue to have headaches. That being said, if you're one of those, then that's an option. But number one, it's not very effective for every single patient. Number two, you need to find a provider who has license to prescribe medical marijuana.
And just to be clear, the three of us don't?
No.
I don't. All right. So the next question came is, how frequent do migraines need to be considered for these therapies?
Dr. Sarah can go.
Which therapies? The procedures, Lisa, or more the medications?
That's all they wrote.
Okay. So in a general term, basically, it really depends on the frequency of the headaches, but also the severity and the duration. So if I see a patient who is having 15, 20 headaches in a month, that already qualifies them for Botox and occipital nerve blocks and potentially other procedures too. However, let's say I have a patient who is having only 2 headaches in a month, but those headaches are very debilitating and severe, and they span the course of 3 days each. So that's still a good indication. That's why the number itself is not necessarily a good indicator of what therapy we're going to be using. And it's really on a case by case. So we usually have a conversation with the patient to see what would they prefer. Do they only want to be on a medication that they can take as a rescue medication? because that way they don't have to take a medication daily, they don't have to do any procedures, and whenever the headache hits, they can just take one medication and then abort it, essentially. And some patients prefer that and go for that option, which is very reasonable. However, other patients say that they don't even want the headache to happen in the first place, and they prefer to go for a procedure like Botox or for nerve blocks, and or medications too, preventative medications. So that's reasonable too, and it's really all about the conversation that we have with the patient and what they prefer, and about the risk and the benefit, and being aware of all those. And usually we come to an agreement as to what they prefer to do.
Wonderful. The last question here is about prevention, using medication for prevention of headaches. And I think both of you talked about that beautifully in your discussion. So I don't know that we need to go over that again. There is an individual who's asking about a Chiari malformation, but I'm going to take that offline and ask you to contact one of these wonderful neurologists and ask them your questions that are not quite as individual as that. That being said, I want to thank you again, both of you, for joining us this evening. I think it was an incredibly educational and informative discussion. And I hope all of you who suffer from headaches take the time to make an appointment to see Dr. Kumar or Seder to help get some resolution of your symptoms, because most of us who suffer from headaches know how much it takes out of work and family life if we can't get it under better control. So just to reiterate, the neurology office is 860-522-3711, and my office for the Women's Health Center or the Women's Health Concierge, ours is 860-236-3000. If you forget either one of these, you can contact our Women's Health Concierge, and she'd be happy to help you figure out where you need to go for your next appointment. So thanks everyone for attending. Thank you, Dr. Kumar and Dr. Seder. I really appreciate it, and have a wonderful evening.
Thanks,
Thanks,
everyone.
everyone.
Thank you,
Enjoy.
Lisa. Thank you, everybody.